Welcome everybody to this session on system solutions to tackling workforce pressures. I'm Anita Charlesworth and I'm chairing the session today. As you can see behind, and in front of you in fact, we've got an excellent panel of speakers. I'm actually going to take lots of time introducing people. If you've got the app and the pack, everyone's incredibly impressive. Biography is in there. There are two things that I guess I want to say by way of opening remarks. Obviously, I think we're all aware that the challenges we face are both short, medium and long-term in relation to the workforce. We are in the eye of a storm, but at the moment, as things stand, the pressures on our system, if anything, grow. Particularly, I want to point out for people that the number of people over 85 in 2030 will be a third higher than it was pre-pandemic. And the number of people in the last year of their life will be a fifth higher than it was pre-pandemic. So the demand pressures on our system are very, very substantial. As a result of that, we know we need more staff, but we need different mixes of staff. We need to deploy staff in different ways, because whilst there are more people who are very elderly, more people at end of life, their needs, that's accompanied by a picture of complex multimorbidity and frailty. So we face a numbers challenge, but the type of care and the needs of people will also change. That's against a backdrop, obviously, of systemic staffing shortages and labour market dynamics in the wider economy, which at the moment are very, very challenging. So real pay for NHS staff has been falling for a long period. The number of young people coming into labour market, competition for workers. There are across the economy more vacancies than people. I will plug last week Andy Haldane, who is the past chief economist at the Bank of England, gave the annual Real Centre lecture for the Health Foundation. It's available online. And he shows in that as well how important having people in the workforce is to our economy thriving. And actually the number of over 50s who are leaving the workforce, who are on long-term sick. So I think it's now 17% of people of working age are actually not in the labour market because of long-term health problems, which is an economic challenge which we just can't afford to have across the economy. The impact of that, obviously, though, is also felt in our service, and whilst NHS is struggling with rising vacancies, the situation in social care is even greater. And obviously we know that that profile that I talked about of need will have implications for social care as much, if not more, than for NHS care. Social care vacancies are up 50%, and actually the number of people working in social care is declining. And we published some work also, sorry, I am losing my voice, you can hear, last month, showing the numbers of social care staff and their families experiencing poverty. So very, very challenging issues. One of the things that's really important, though, is alongside having enough staff, as it were, having staff who are skilled and organised to meet that rising need and changing need, it is really important that we support staff and run our systems to enable people to work as productively as possible. And one of the issues coming out of COVID, which you'll all be aware of and is very hot in public policy discussions and in the media at the moment, is that NHS productivity is declining. And one of the factors that we see is that obviously one of the ways in which over at least 20 years we've delivered more care, but with staff numbers growing at a lower rate, is reducing average length of stay, increasing day cases. Over this decade coming, without any further productivity improvements, we would need nearly 500,000 extra staff. But if we can continue to reduce length of stay, to continue to improve day case rates, that falls to around 300,000 staff. Thank you. It is the most massive difference in numbers. But coming out of COVID, average length of stay is actually rising, not falling. So a lot of systemic challenges. I've outlined what those challenges are. I think they're well understood now. Our speaker's task is to identify solutions to those challenges. So the session today is focused on solutions, and it's focused on solutions that think about this systemically. And I think that's really important. Systemically, in terms of NHS and social care, all the different parts of the NHS, thinking about that changing needs, and systemically thinking about the whole range of solutions that we need to the workforce. No one policy is a silver bullet. Yeah? And we have to pull all of the levers: training, recruitment, retention, optimization of skill mix, all of the above, if we are to be able to have enough staff, ensure that we're able to improve productivity for taxpayers, and give staff a meaningful and positive working experience. So, in addition, could I have the next slide, please? Oh, no, back one. In addition to the panellists providing their insights into system solutions, really hope that you will all contribute as well. And we've got a whizzy gadget to do that, okay? So if you're all right, could you all log in to Glisser? And the QR code is there. And if you could take a moment to do that now. As you're hearing people's reflections in their opening remarks, and I'm going to give everybody 5 to 7 minutes for their opening remarks, you can start sending in questions and comments as you go. That is actually super helpful, because what we'll try to do, because there's a lot of people in the room, which is a lovely problem to have, is group some of those together as well and make sure that we cover all the different themes. And I do invite you to share your experiences. So I'm really happy to hear comments and reflections as much as questions, because all of us have really valuable insights. So if you've managed to get that working, and hopefully people getting that working? Yeah, looking good. Excellent. Good, because I'm not really in a position to offer technical advice. We thought we'd do this without slides, because probably had lots of PowerPoint. And we try and have a conversation in the panellists and in the room. And we've got a lovely range of perspectives. So we've got the national perspective from M, and then we've got the social care perspective from Nadra. Very importantly, third sector, and I'm really delighted that we've got third sector here as well, and then provide a perspective from Nick. So I remind all of them that we're in the solution space. I got the easy bit. I got to name the problem. Yeah, you have to come up with solutions, and again, encourage you to think systemically. So I'm going to hand over now to you, Em, for your thoughts and reflections. Thank you so much.
Thanks, Anita. Should I use that?
Yeah.
Does that work? Yeah. Good afternoon. My name's Em Wilkinson-Bryce. I'm the National Director for People. And I thought it was interesting that you used 2 of my frames, Anita, in the more people working differently. And I want to add a third, because what I think we all know is that having more people, yes, people working differently, yes, but how people experience work is actually something that became very, very much front of mind throughout the pandemic. And I think we've learned a lot about what people need to be able to stay well in the NHS, but also to be attracted to work in health and care. So I'm going to use the more people working differently, but I am going to also talk about the compassionate, inclusive culture piece. And often it's the bit that gets left behind. And I think actually what we know from a lot of the retention work we've been doing, if you talk to staff about what matters most to them, it's often having enough people, but also how they experience rocking up for work every day. So I don't make any apology for doing the bit that, so as a nurse, I've been used to being called many things, but since I've been doing this job, people always say, oh yeah, you do the pink and fluffy bit. And I want to prove that actually, no, the pink and fluffy bit actually is the hard edge. And actually, if we don't think about all those three things in balance, then actually I think we will see even a greater leaver rate than we have currently. And I also want to share some experiences and some examples of system working that is starting to emerge from across the country. So if we think about I'm not going to repeat some of what you've already said, Anita, but I think the financial outlook is really challenging. And on workforce, there is definitely a need for us to demonstrate how we are thinking about the different, and also responding to what workforce are telling us, what our colleagues are telling us. And through the work that I've been doing on retention with the team, flexibility comes up time and time again. And I think there's a real challenge for us to think about what does flexible working mean within an organisation, but what does flexible working mean at place? And what are the opportunities that we've got to really think quite creatively and laterally, and also respond to what staff tell us, particularly our millennials and Generation Z, who really are very clear they just won't come if they don't get what they want. And that sort of loyalty, that vocation of being in the care sector is not something that they naturally talk about. They talk about wanting flexibility, wanting high reward and recognition for the job that they do. And one could argue that that's right, and that's probably what should have been the case for many, many years. So I think we're seeing some real examples of the workforce challenges that are being solved at system level as we see clearer the sort of advent of ICSs. So we, as New NHS England, obviously have our new operating framework, and the role nationally is really to work alongside delivery partners in regions and systems, and to really gather the knowledge of what's working well and how do we support spread and scale. And I think, I'm sure if we added up our collective years in the NHS in this room, it would be in the thousands. I'll contribute 33. And I think my reflection is we still aren't very good at it wasn't invented here, but we'll do it anyway. So how do we look at what's working in parts of the country and lift it and adapt it and adopt it? And so there is something about how we identify some of the really good practice. So for example, if we look at more people, Frimley ICS have developed a system-wide reservist model, and what they're looking to do and are doing is they're transitioning their vaccination workforce into reservist roles. So there is a contingent workforce set for being able to respond to surges, for example, throughout winter or in the event of an outbreak of some sort. On the working differently, some fantastic examples of community diagnostic centres, and I want to sort of call out the one in Barnsley, where they've introduced new roles, and that's freed up the capacity of registered staff to be able to create time for more training and more care, direct patient care. And what Barnsley have also seen is an improved productivity, and they've got multiple tests now being done simultaneously, and they're also demonstrating improved patient experience. And then on the compassionate and inclusive culture, Sussex ICS have implemented the 6 national high-impact actions on inclusive recruitment, including looking at how they've got improved diversity in job advertising and advert content, as well as some of their more diverse policy and training delivery. And then at a regional level, if we look at the South East, they've got some really impressive results starting to come through. They've increased the likelihood of black and ethnic minority candidates being appointed from interview. So previously, their white candidates were almost twice as likely to be appointed, and this is now down to 1.5 times as likely. And that's a really important shift if we're talking about celebrating and harnessing the talents of everybody that we've got in the workforce. So I just wanted to give a couple more examples. And I saw this one with my own eyes, and this is something that's happening in Somerset, where they are reaching out into their communities and actively seeking to find people to come and work as part of their workforce. And then they're putting really significant wraparound support around people who were either recently made redundant or who have been unemployed for a period of time. And at the moment, they've got a programme that they're running, and 96% of those people that started the course have gone on to attain full-time employment. So in terms of that, not just expecting people to be magnetically attracted to the NHS or to care, actively going out and reaching into communities and finding people and making the access to be able to join our industry, our NHS family, is really important. We were really delighted last week to sign the Care Leavers Covenant at NHS England, and that is again massively important so that we can create opportunities for people who've grown up in care to have a meaningful career in the health and care industry. This is one of the best distractions I've ever had. I'm keeping going. And we're going to be working with 10 ICSs to begin with, and we're looking to really expand that very rapidly across the country so that we can provide an access into employment for care leavers. And then lastly, I just want to specifically reference integrated planning, because I think we talk a lot about the need to really integrate workforce activity and financial planning. And too often, we've done them in sequence but not simultaneously. And it is absolutely going to be critical that we maintain that three-legged stool so that when we're thinking about providing the new models of care, we're automatically thinking, what's the workforce model that services that care model, and then how do we get the return on investment for either through productivity or more patients being seen, reducing backlogs, etc. So I think there are big challenges ahead, and I'm still very connected to people at the point of care and actually still work clinically for the very reason that I don't ever want to sit here and not be realistic about how challenging it is. But there are some fantastic opportunities coming out on a weekly basis from across the NHS and care. And I think we have to gather those and really challenge ourselves in terms of why are we not adopting those? Why is there so much differentiation across the country? And actually, I'm really hopeful that there are some really promising signs of how we can really start to breathe life into the more, the different, and the compassionate culture.
Thank you very much. Thank you especially for, that was the most novel form of heckling I've ever seen. You did amazingly. Nadra, over to you.
Thank you very much. And firstly, thank you for inviting social care to your event. I think it's important that we are here and hearing some of those messages too, and I hope some of the messages we can give will also be helpful. So I've worked in the field of social care for over 40 years, having been a provider at the outset. And what I want to say to you, the reason I'm mentioning that is because the provider that I was in 1981, when I opened my first care home, does not resemble the social care that is being provided in care services today. And I think that shows how social care has evolved and been very solution-based. We've raised, as expectations have been raised, so social care has met those and continued to deliver. Sadly, for social care, it hasn't continued to enjoy any of the resource that might have followed, and that's why we are where we are. Social care does play an enormous part in the welfare of over 1 million people every single day, and I think that sometimes gets forgotten, and that it does employ more people than the NHS, and at this moment in time obviously we have more vacancies than the NHS. And our workforce is key to delivery, because our delivery arm is also, it's not all about care homes, which is what you'd think it was, because that's all you ever hear about. But of course we have home care, we have learning disability services, we have community services across the board. And all of that continued to deliver, just as the NHS did through COVID. And I think that's really important, that we were all in this together. We were delivering at the same time. So we are very solution-based. We do look after people with very complex health and social care needs now. Used to be just social care. I didn't take anybody in my home who was incontinent when I started in 81. I didn't take anybody who had dementia. We had Pleasantly Confused. It was a cream tea society. People sat on the lawns and had a lovely cup of tea and had some company. That's what we did. We bathed them if they let us, but once a week if you were lucky. And that was the service we have. What we have now is ambulances arriving with a very different type of client. But our social care staff have had to be upskilled and not recognised, and I think that's another major issue for our sector. When I often use this, I'll use it here as well. In a hospital setting, a nurse comes round and does the drug round. In a care home setting, it's our staff that do the drug round. They're trained to administer that, and yet they're not recognised for it. So I think it doesn't kind of, it's not rocket science that they feel quite undervalued. They're delivering something that is akin to their colleagues, and yet they're completely undervalued. And very seldom, and I'd love to have been here tomorrow to hear if the Secretary of State will even mention social care. Let's see if he does, but it's very seldom that politicians even mention us in a very positive way. One of the challenges that we face now is obviously the pay, and I can't kind of get away from that. So we upskill people to such a level, but when we're commissioned to deliver, we're delivering at the national living wage, which is £9.50. Whenever the national living wage goes up, the commissioners do not use that as a way of increasing the value of social care. So providers have to do that through their own means. I think the other thing I would want to say is that social care doesn't solely exist to support the NHS, although it's a very important part of what we do, but it is a standalone sector. It does have its own role, and although I've heard about integration for so many years, I don't see it happening very often. And one of the things I've always said is the easiest methodology would be to work on the workforce. Let's integrate the training and education that we have across the workforce. One of the challenges we face is that we do not have a career pathway that people can come into and actually go up a ladder. If you work in 82% of our sector is small to medium-sized providers. There's only so far up a ladder you can go because there's the owner. And so you can become a registered manager, you might be able to get to a senior role position, but actually unless you go away and then start your own business, you're not going to get to that top slot generally. So actually the NHS benefit from this. They benefit from it because we will have staff leave to go into nursing. And when I was running care services, I actively used to promote that and say to my staff when they got to a certain level that had they thought about going into nursing, we should be using that much more. And actually the other side of it is when people are thinking about retiring out of the NHS, perhaps we should be thinking about saying to them, perhaps you'd like to go and look at what social care might do. Of course it would be a salary drop, which is a separate subject, but it is something that we could be actively doing and promoting, and I think that would be really good. Our purpose is to support the citizens who need us when they need us. And I think that is the key to everything that we do. Currently, I'm sitting on the discharge workforce, on the task force for discharge planning. And we can see some of the challenges that we face because of that. And some of that is because providers do not have a workforce to be able to take the residents, the patients that are coming out of that service. And actually we can remedy that, and one of the things that I am talking about consistently is that the challenge we face with discharge and workforce is that if our workforce felt that they could be supported clinically for a very short period of time, it could be 3 days, it could be 2 days, it could be 4 days. So when somebody is discharged out of a hospital setting, they still have some clinical support from the NHS, which means that if the drug is wrong or something isn't quite right, they can still call somebody who's looked after that person for a period of time, got them out of the acute stage, and so we can then build on that and develop. And that's one of the things that we're really trying to push. It's not because people don't want to take people out of hospitals, which is what we keep hearing about. It is because they just don't have the confidence that they can deliver the level of care when somebody is coming out post-stroke or with Parkinson's or somebody who's had a heart attack. My father's currently in a hospital right now, and they keep telling us he's medically fit for discharge. We had 3 failed discharge pathways, and he's ended up once within 4 hours back into the hospital, once within 10 days back into the hospital. So let's get this right, let's get it right so that the staff that are receiving people feel very comfortable and confident. And part of that is to do with the training. And I go back to the shared training. I think integration, workforce-wise, if there are training sessions going on within NHS settings and there are care homes around you, let's work together and try and put people together into that setting so they feel confident when they come out that they have got the same level of training. I'll stop there, shall I? Have I gone on too long?
Well, it's fascinating. Ellie, we're moving to the third part of the workforce, I think, and very importantly for health and wellbeing, the third sector.
Thank you. And I'd just like to say thank you so much for inviting me, but also just what a delight it was to listen to the panel earlier on the main stage, really talking about the role of the voluntary sector. NHS Charities Together, for those that don't know, is the national charity caring for the NHS, and we're the membership body representing 100% of the NHS charity sector. So that's in every trust, every hospital, ambulance, mental health, community health, and across all the health boards. And I'm delighted to be able to talk about the wider voluntary sector as well. And if I could have you take one takeaway from me today, that would be to really try to understand the voluntary sector, including your NHS charity, as a partner, as a strategic partner, as a systems partner, as a funding partner where that's possible, and as a culture partner, building on what Em has said earlier. And one of the ways that we're trying to do that as NHS Charities Together in understanding the system is firstly by mapping the system. And that's something that we are doing as an organisation to really understand how can we as a sector of NHS charities and as an organisation as NHS Charities Together help and have most impact across the health and care sector. But that's something I would encourage you all to do as well, because quite often when we talk about systems work within health and care, we talk about primary care, we talk about secondary care, we talk about the local authority, we talk about the wider care sector, but we completely miss out the professional role of the voluntary sector. And there's 3 areas that I'm going to concentrate on now in terms of solutions. The firstly is volunteerism. So we mapped very, very briefly, I will say, there's some more work doing on this, on both the workforce and patients, how and where volunteering helps across the system. So firstly, let's look at attracting more people into careers into the NHS. So youth volunteering, young people. NHS England has a programme called NHS Cadets, which is in partnership with St John's Ambulance, and they've got the commission to deliver that. And that started off as a pilot in 2020 and continues to grow. And that's an opportunity at provider level that you can take part in. Pre to that, another partnership between NHS England and the wider voluntary sector is the Young People's Health Challenge, which actually starts at 8 years old through to 14, working with schools and youth organisations to be able to grow the understanding of the NHS and health, as well as careers within the NHS. And the wider so talking now about Helpforce. Helpforce have a programme, some of you will have heard of Helpforce as a volunteer organisation. They have a programme called Volunteer to Career. We've seen across the pandemic the increased role of volunteering, and we know that greater and more volunteers within a provider setting actually takes the pressure off the workforce as well. So taking the pressure off the workforce, but equally bringing more people into careers within the NHS. And looking at roles that volunteers can do, we've become quite risk averse, I think, in thinking this isn't a role that a volunteer can do, because we think that a volunteer means that they're not professional and it's amateur. Well, amateur means for the love of, and some people that volunteer are highly professional. And so creating and looking at ways that more people can volunteer. And then I want to give 2 examples of wider volunteering. So Helpforce have piloting a programme with George Eliot Trust in Nuneaton, looking at how volunteers and voluntary sector partnerships can support people on waiting lists, so that they are ready for, that they're not lost in the system on the long waiting lists, but also by the time they get to their procedure, they're more supported and they're turning up ready for that procedure with all the things that they needed to happen. And then looking at people leaving a provider environment, how can volunteers help with that? And I'm going to come on to more about voluntary partners in the voluntary sector. The other area in terms of volunteers is we put £7 million into the ambulance service over the last year, particularly to build and grow community first responders. And that is a huge area of being able to help take the pressure off those services that are ending up in A&E, being able to support early enough, and it's volunteers that are doing that. The third area to consider is funding. Certainly your NHS charity is a really good source of being a funding partner across the whole of that system. And one of the really exciting things that charity funding can do is pilot things, test and learn, and so you can tell whether it's going to work before you decide to put statutory funding into that place. You can prove and then you can scale. And some of the really exciting areas where charity funding really helps are things that are de-stressing the workforce. So one of the areas we looked at is how do we keep people in the workforce? We've heard that, Amazon pay better, and, there's a mass exodus of people wanting to go and work for Amazon or going to work for another organisation. So how do we keep our amazing workforce in the workforce? So de-stressing. The Royal Free Charity, this is quite a few years ago now, pre-pandemic, funded a digital rota for their ICU so that people could self-choose when they were going to work. And I'm just going to give you the statistics of that. Staffing was a huge issue for, and the rota was a big area of demotivation. And it was an old paper system as well. So the charity funded the digitalisation of the system, and it reduced the annual turnover rate of staff from 40% to 22% and gave an annual saving of £250,000. Training is another area where your charity can really support fellowships, and volunteering as well in that. Another area that we looked at is the huge recovery of the mental health and well-being of staff. And we were privileged to be able to lead the nation's support and love and response to the NHS during the pandemic. And I'm very proud that we've been able to put £140 million into the sector to be able to support that. And that includes creating physical spaces for the workforce to have breaks, care packages, food, psychological support, wellbeing leads, peer-to-peer training. The latest grant that I just approved includes a mental health nurse practitioner for staff, as well as a physiotherapist for staff, because the two biggest reasons for absence are mental health reasons and musculoskeletal reasons. Equipment is another thing, whether that's equipment for your patients or equipment for staff. So things like lifting chairs for ambulance services, as well as huge reams of capital support as well. And one of the things that technically and that funding can do is that if you've got match funding from your charity, it is a real lever to be able to get statutory funding or wider funding. Not saying it should replace the funding that you've got, because it will never do, because the amount of money within certainly the NHS charity sector is minute compared to, and we're talking 1% of the overall budget of the NHS. But it's a real lever, and using that lever can be a real help. And finally is the healthy communities and partnership with the voluntary sector. I'm really proud that we've put £33 million into the voluntary sector over the last 2 years, knowing that the NHS does not work in a silo. You rely on your partnerships with the voluntary sector, helping people in place where they are. But one of the things that I think we need to do better is to demonstrate that to providers. So that includes communities that have been disproportionately impacted by COVID, really working within those to reduce those health inequalities. Over the coming year, what we want to be able to do is really evaluate those so that some of those solutions are coming to the forefront and that we can share them with you as providers. Just on a practical note, something that we can't do within the voluntary sector, but really want to be able to support on. So we're looking in partnership with NHS England, looking at a pilot of some support around spaces within an ICS, and wanting to be able to provide and fund, and the funding is there, funding has already been given, to provide wellbeing and breakout space. Now, as we become more integrated and different people from different trusts are accessing and using the same play space, the same provider physical estate, if they haven't got passes that allow access through the estate, then the systems approach can't work. So it's looking at that mapping within a system of who is part of this system, and how can we best use everybody within that, including the voluntary sector. And some of that is just about reducing some of those barriers at a very easy level, and some of that is about seeing the whole of that system and mapping the whole of that system. But the voluntary sector is there for you to have as a partner. They want to work with you, and your NHS charity is there to be your strategic partner. And so please use us. Thank you.
Thank you, Ellie. Nick.
Thanks very much. Good morning, good afternoon. I was just thinking of the distraction there. It's not the first time as a chief exec I've been distracted by a noisy chair. I just hope my chair's not in the room. Anyway, good afternoon. Here all week, end of the pier. So I just want to take you on a bit of a journey, if I may. When I started working at Colchester about 7 years ago, everybody talked about Jaywick. Jaywick is the most deprived electoral ward in the country. And I kept hearing about it, and finally, due to a complaint, I went to visit a family in Jaywick. And that family have become so important to me in terms of my leadership journey over the last 6 years. They've become my kind of touchstone through COVID and everything. When stuff's going on, I just kind of go and see them or go and visit them and saying, how's it working for you? So I've got to know them quite well. On about the third visit to the family, the mother said to me, I suppose you're going to ask me about my mammograms and my smears. I thought, well, it wasn't going to be my first question. I did work in sexual health for 10 years, so I'm quite used to it. But and she said, so when do you think I'm going to go, Nick? When am I going to get the time? I'm more worried about paying my rent, my ex-husband not beating me up, feeding my kids, heating my home. And it's so difficult to get, it's 3 buses to get from Jaywick to Colchester Hospital. So we then had the opportunity to develop one of the community diagnostic centres at Clacton, and you heard Bola talk about Clacton this morning. Jaywick was used by Donald Trump in the midterm elections. He put up photographs of Jaywick saying, if you vote Democrat, you'll end up living like this. That's the level of poverty. I've never seen anything like it in this country. So it was a great opportunity, great investment, but of course we had to staff that unit. So we developed a joint venture with ourselves, East Suffolk and North Essex Foundation Trust. We managed Ipswich, Colchester Hospital and Community Services in North East Essex and Ipswich and East Suffolk. We then worked with the Colchester Institute, a fantastic, innovative higher education organisation in Colchester, the National Careers Service and the Department for Work and Pensions. And we put together a plan to develop a community diagnostic training academy. We were very specific that we would only take people from tendering, and we had some local money from tendering local authority to invest. Just to give you some idea about tendering, 78% of the families in tendering have £125 disposable income a month. £125 disposable income a month. So when I bought a round of drinks last night, I have occasionally bought a round of drinks, that was half of a family's disposable income for a month. Quite levelling, isn't it? So that's the level of poverty. So we were very keen to develop opportunities, but we're also being pragmatic. We had to staff, and we wanted to staff from local people. So we got some short-term pump priming funding for that through the Community Renewal Fund. Again, working with local authorities, looking at the money that's available. There is so much money available from the EU. No, not from the EU, sorry. There's so much money available, work with me on this, that is available. There is still European money available. There is still renewal money available. So please, in your local communities, particularly through local authorities, it's worth talking to them. Really focusing on local level of support. So what do we say that we'd do? We would invest in skilling up 133 adults, all of whom are either short or long-term unemployed, and develop them through care and training, working with the Institute to offer them employment opportunities. We've supported 90 people now through that programme, and we've developed 50 of them into NHS roles. What's been really difficult is not all of them have come to work for ESNEFT, and I've been really pleased to allow them to go and work in other, and no, I haven't. It's been really, that's what it says on my slide. there is something about we have to invest, and if we're going to work at a system level, we have to let people go. And so this is an investment not in ESNEF, not in making sure that we have reporting radiographers in a few years' time to work in Clacton. It's about a contribution to our system. That really hurts. It really does hurt, but we have to be able to do that. It's been absolutely incredible. I went in the second or third day it opened to meet a receptionist there who'd got there 2 hours before their shift started and stayed 2 hours afterwards because they just wanted it to be perfect. And with tears in his eyes, he was telling me he'd been unemployed for a year. And you can't, there's nothing that can kind of make you feel better about what you're doing. So that real partnership working with the local authority, with the local higher education establishments, creating the academy, letting people go, and giving them the joy and the opportunity of developing careers. Thank you very much.
So in the, in your reflections and borne out then in the comments and questions that are coming through, this is a very different way of working. This is a system way of working. This is deep into communities way of working. This is partnership across professional barriers, across organisational barriers, across cultural barriers. All of that actually is really hard to do. It's incredibly worthwhile, but it's really hard to do. There are lots of questions here about, firstly, when we're going to get NHS, a national workforce plan, but actually how we do this at system level, because none of the comments, none of your reflections, no one when I go out to speak to people says I'm opposed to doing things at system level. Actually, diagnosis is pretty clear. But how do I start? And how do I start doing that so that it actually makes a material difference? So that we can go from outstanding examples that, we all want to go and see and bottle to actually this happening across the system. Because you're all describing incredible practice. And then I look at the staff survey and it makes you want to weep for the wrong reasons. Whereas you describe an example of making you want to weep for all the right reasons. So, perhaps I'll come to you first. Sorry, but nationally, how does NHSE see us going from understanding what we want to do, what success will look like, the approach we need to take, those wonderful examples, deep commitment locally, to actually making this happen systemically across a lot more of the country?
Thank you. So the two big things, and you specifically said about the long-term workforce plan. So Amanda spoke at the Public Accounts Committee last week and said, when she was questioned about that, the intention is for us to have the long-term workforce plan by Christmas, but no later than the end of the financial year. That will then be put to government, and then what gets published, of course, is a matter for them. But I think the point that you make about what does it take to get to where the example Nick gave, for me, and I'm sort of going back a little bit to my job before I came to do this one, where I led on integration in Devon, and my reflections would be, it was all about the relationships, it was about the trust and taking risk, and it was also about the leadership. And I think if I then pull that back to job now and the role of NHS England, the Messenger Review is really important because it talked about moving from competition to collaboration. Have we got leadership capability, capacity, have we got management capability and capacity that really is going to take that forward? Because, and I think so much of this is best done at local level, but for us at national level, I think the long-term workforce plan is key. I think how we set up taking forward the recommendations in Messenger, particularly around management standards and professionalising management and managers, with a view to moving from competition to collaboration, is going to be a massive step forward. But I do think most of this happens, the magic happens at local level.
Brilliant, thank you. Nick?
we're interesting as leaders, aren't we? Because we keep saying we need a national plan, and then the minute we get it, we say, oh, that's far too constraining and doesn't give us the local flexibility we need. So my view is, I think the national plan's important, but just crack on and do it. I think just waiting for that, it's not going to change anything. And it might change things for the future, for the next generation, for my grandson who's just been born, whatever. But it's not going to move the dial immediately, and the need is now. So I think, yes, we need the framework, and yes, hopefully the plan follows investment. But, we're great, aren't we? Oh, no, we can't do anything without a plan. Oh, no, we don't need a plan. We just need to get on with it. So let's just get on with it, because we have got that leadership. We have got that commitment. We have got third sector partners. We have, I think, we are developing. I don't think we're anywhere where we need to be. We're developing a different relationship and a lot more respect, I think, for social care. So I, yes, and I think would be the answer. It is about local relationships. It is about longevity. It's not about this bloody churn of chief execs just give a bad week in the office. So let's do that.
Nadja, can I ask you a question then? Expanding this out, some of the things people are saying. In the comments, lots about thinking about integrated health and care workforce being absolutely critical to integrated services, integrated care. So West Street is going to be in the main hall this afternoon. Labour are thinking about National Care Service. As part of that, they're thinking about do we need agenda for change to cover social care staff, but is that a very NHS view of the world, which is, here's a partner, we'll take them over, as it were, and impose our way of doing things? Or, but even if it's not that, and I'd be interested to see what your reflections is, do we need a registered workforce for social care, or do we need a wages council? Pay has got to be part of this, obviously, but also this, you talked about about training together. Where do you sit on kind of bringing the workforce together more formally? What's providers' kind of views on that? I confess personally, I'm in two minds. Clearly integration matters, but as you said at the start, social care does not exist as a support service to the NHS. And actually, in some ways, when you start to think about new models, we need the world to become more like social care, more focused on well-being, more kept focused on starting with the individual, seeing care in a social context, more comfortable to take some risk, more comfortable starting from the person's desire, and actually an NHS, extending the biomedical model could be a massive step backwards. So interested in your reflections.
Thank you. I think for me, we don't want to go backwards. I think it would be a real challenge, and we've had conversations with the opposition on their plans. What's really important to recognise is you never throw out the baby with the bathwater. You've got a model. The reason that local authorities had to close their services was because they just couldn't handle the expense of it all as it developed. And the care providers have come in, they're entrepreneurial, they're innovative, they've moved the agenda, and actually you can walk into some of the care services now and they are just, superb. They're great services, and we've all got care quality commissions, we won't go into that, but we've all got somebody to regulate. I think that the thing for me about registration, I think there's got to be something that brings the value into the service, so people do feel valued, and social care can stand alone and be a career pathway, and then that does mean that there will be financial reward for them. So I think that's really important. I think working across the two is a benefit to everybody, especially the patients, that we are, we're all looking after the same people. So people are coming out of care homes into hospitals as well. So I think for me, that is really, really important. The resilience in the social care sector has been eroded. There's no doubt about that. And it does need to be rebuilt. And, shelving reform doesn't help us in any way. Workforce will come to the NHS. The mandatory vaccination fiasco showed us that they just transported straight across to the NHS, and that should be a lesson. And for me, if we can get our workforce registered, we get the right qualification agenda into place, we get them registered, we show them that there is a career pathway, which may or may not include the NHS. But in a care setting, we do have many careers. We have chefs, we have administrators, we have IT, we've got housekeeping. I mean, it is a hub of activity. So it's not one single thing, it's many things.
Ellie, a question I want to ask you first is lots of points in here from people about the importance of informal care, importance of carers, and again, coming back to my opening remarks about changing care needs and long-term conditions, a model which is done to rather than done with won't work. Could you say a bit more about how you see and how the voluntary sector sees the NHS's challenge in and progress in really embracing that partnership with informal carers?
Thank you. And I think informal carers, unpaid care, a huge area that's not new. And I think, I think there's probably I'd look at this from a wider and a larger perspective, which is partnership working, full stop. And for partnership working to really to happen well, we have to acknowledge that we're not always the same, and difference is really important in partnership working, but also a respect of the difference that there is, and I think when we look at partnership working, whether that's with informal carers, unpaid carers, or any part of a wider sort of volunteerism or voluntary sector, is that thinking that this isn't professional, or or because this isn't professional, it is therefore of less value, or we need to set the rules, or you have to play and dance by our tune. So within any partnership working, really setting out a really good, I'm going to use the word service level agreement, but within a service level agreement, all you do is go, this is who you are, this is who we are, this is what we're really good at, this is what you're really good at, and these are the terms in which and how we're going to work together, and this is the collective outcome that we're going to have. Now, to me, that works across any partnership, not just how to recognise and partner with informal care. I think there is then a bigger response in that, in terms of the governance recognition of informal care and unpaid carers, and a recognition of where that is within the sector, whether that's caring for children so that people can be part of a workforce, or whether that's caring for other people that have other and additional caring needs. But I see it as probably a wider cultural understanding of what partnership means, of actually understanding and valuing the difference, looking at what are the things that are stopping us from working together. Because we're focused on the outcome, we're not focused on trying to make ourselves the same.
Excellent. So final question, topic area that I'm going to end on, because I'm an economist, is the issue of productivity. And one of the challenges at the moment, writ large across the newspapers, and you might ask our Secretary of State some questions about this tomorrow. Apparently this is quite live in his discussions with the Chancellor, is staff numbers are actually up compared to pre-pandemic, but activity is down, productivity is falling, what's going on? So one of the questions is, are we actually observing that cost of not looking after our workforce where we've got quiet quitting? We've been dependent on discretionary effort and goodwill, and are we losing it? and what can we do to get it back? Because if we are, it's a major challenge. Em and then Nick.
I think I go back to the extensive engagement that we've had with all aspects of the workforce through the retention work. And what does matter to people is they feel seen, heard, recognised, valued for what they do. So I think a belief that what was very prominent in the pandemic is going to endure comes up a lot. So there was a lot of focus on health and well-being of the workforce throughout the pandemic. People are suspicious that it will be the first thing that gets cut. There was a lot of conversation about reflection, about the value of people processing what it is, the cognitive load of being in a care workforce. And I'm not just talking about clinicians. You know, how a receptionist greets somebody, how a cleaner is confided in, because often they are the people that patients want to speak to. Those are the things that are really important. So I think it's incumbent on all of us to say that the productivity is not down because staff don't feel valued. And that's in the gift of all of us in terms of how we lead, how we create environments where that is true. So it's not an easy, I don't have a golden answer to it, but I suppose it is something that drives me to want to continue in this space, because I just think when I've seen the most beautiful care happen, it's because someone has given something of themselves. And that's the thing we must treasure, because without it, it becomes a mechanistic health and care service, and it is a humanistic health and care service that we want.
Nick.
If only I knew the answer. I mean, I think it's really difficult because the narrative from number 10, Cabinet Office, DH, Treasury, is all about you've got more money, you've got more staff, and you're doing less activity. Why? And I think as leaders, that's a really, really difficult answer. I was talking to the Bishop of Colchester. I don't spend a lot of time with bishops, but I was talking to the Bishop of Colchester recently, and he was describing exactly the same challenges with his workforce, the vicars, as we're finding with ours. A real sense of them feeling very low, feeling undervalued. For me, there's something about an incredibly energised country, not just a workforce, a country around COVID, and a point at which you were going to get out of it, and you could do something to get out of COVID. You could wear your mask, you could have your vaccine, you could stay at home. We came out of COVID and, hey, things are worse. Things are worse. Poverty, inequalities, cost of living. And I think that there's a real sense of, not just with our workforce, but in society, of, so what do we do to get out of this? And a real sense, and I'm finding it, with my friends, with, and we're the lucky ones, aren't we? We're the incredibly entitled lucky ones. And for most people, I think it's really difficult. I don't know the answer. I think the difficulty is that we need to provide the balance of protection from number 10, Treasury, Cabinet, ministers, whoever, particularly, dare I say, some of our current leaders, where that mantra is becoming stronger and stronger almost daily. But also reflects to our workforce that question. What is it that means? Yes, we could argue, well, patients are more complex because we've been waiting times longer, so we could only do 3 analysts and not 4. Yes, there's that bit. But in the days when, if you had a 1-hour delay in the ambulance service, ambulance on the acute chief executive in the room will know this. It was an SI, and you're investigating it for weeks. And now nobody bats an eyelid if it's 20 for 20 hours. And yet there are less patients coming and being admitted to ED. How do we answer that question? I just don't know. And if anybody does know, I'll be at the back at the end of the meeting. It'd be great to hear from you. Thank you.
I've overrun. I'm really sorry. That was such a great conversation. I hope you thought that it was real, yeah? That there, where we want to get to, I think we're all clear and there's remarkable alignment. It's very humbling to think just how big a challenge that is. But also some of the examples people gave here what a prize if we can do it. So it's worth fighting for, isn't it? So I hope you enjoy the rest of the conference. Thank you for amazing questions. Sorry I didn't get to them all, but I hope I gave a flavour of the things that you were raising. And enjoy the conference. Thank you. Thank you to our speakers.